Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're starting a brand new series entitled X-rays and medical research in the QME evaluation. And I have a fascinating program for you that's chock full of brand new ideas that I'm certain will make a dramatic and an immediate impact on your QME practice if you will only implement the ideas contained within this program. Now, in approximately 6 hours from now, when this program concludes, you and I will both have an epiphany and a realization, and that is that the entire purpose of this whole program was one simple thing, and that is to help you improve the content and the quality of your QME reports. And I have dozens of ideas to share with you surrounding two simple concepts. Number one is ordering the necessary diagnostic studies that are required by the AMA guides, which many doctors fail to order the necessary and required diagnostic X-ray studies for their evaluation. So that's number one. And then number two is to perform necessary medical research for the resolution of disputed issues and incorporating your findings of your medical research into your QME final report. If I can convince you to adopt these two procedures, ordering necessary diagnostic studies, and number two, doing necessary medical research, is going to dramatically improve the content and the quality of your report, and it will also impact the complexity level that you're able to bill your report for. Now, this may come as a surprise to you, but the Division of Workers' Compensation favors reports that include medical research within the body of the report. So the Division of Workers' Compensation has no problem to begin with, and they actually prefer, encourage, and favor reports that include medical research within the context and content of the body of the report. But many doctors fail in these two procedures. They fail to order necessary diagnostic studies to begin with, and they fail to embrace the opportunity to include medical research within the content and the body of the report. And I want to talk to you in great detail and great length, and we're going to go through a great dissection of these two topics within this series. And then I'm going to share with you five examples of cases that have included medical research within the body of the report. And I'm going to share with you how the medical research dramatically contributed to the opinions and conclusions of the qualified medical evaluator's report, and how the medical research was pivotal, and how the qualified medical evaluator could not have, without the medical research, could not have provided opinions and conclusions that qualified as substantial medical evidence in the absence of medical research, which supported the qualified medical evaluator's opinions and conclusions in the end of the report. So many times qualified medical evaluators are providing opinions and conclusions in the report that really do not qualify as substantial medical evidence because they're not supportable. They're simply the evaluator's opinion. They're simply the evaluator's opinion. And I'm going to share with you some references from the DWC itself that encourage us as qualified medical evaluators to support our opinions. Okay, so it's one thing to provide opinions. We are required to provide opinions. It's entirely another matter to support those opinions and conclusions with references from the literature. References from the literature. And it's the medical research that allows us to reference the literature. So when you provide opinions and conclusions, in order for those opinions and conclusions to qualify as substantial medical evidence, they need to be supportable with how and why reasoning. Well, the best way to obtain how and why reasoning is to have references that support your reasoning. And many doctors do not take the opportunity to incorporate the medical research within the content of their report. And I'm going to share with you 5 examples, 5 fascinating examples that will thoroughly indoctrinate you into the many opportunities that are available to you in your reports for incorporating medical research into your reports. So I have a fascinating program for you, and I hope that you enjoy it very much, and I hope that you will adopt these procedures with your very next evaluation. Okay, so with that as our introduction, let us begin. Okay, so when we talk about incorporating X-rays and medical research into your QME evaluation, this is going to be the sequence of events that we're going to follow. Number 1 is to, in every single case, we're going to order the necessary and appropriate and required diagnostic studies. Now, in chapters 15, 16, and 17 of the AMA guides, X-ray studies are required for the assessment of many impairments. And we're going to go over those impairments which are required to be supported by X-ray studies in just a few minutes. But the first thing I want you to get into your mind is that on every single case, you're going to be ordering diagnostic studies. And I can't tell you how many times I review qualified medical evaluators' reports, and when I discuss with them over the phone, did you order such and such X-rays? They will tell me that they did not do that, and they will list a myriad of reasons as to why they did not order the necessary diagnostic studies. And not a single one of those reasons is valid. Not a single one of those reasons is valid. There is no valid reason for failing to order the diagnostic studies that are required by the AMA guides. So on every single case, now there may be 1 or 2 exceptions, but the principle is order the diagnostic studies on every single case. And I have other videos to share with you how to get this done in an efficient and time-effective manner so that the procedure doesn't kill you, because the procedure can be cumbersome. But I have other videos to explain to you how to do it quickly and easily. But for now, just get it in your mind that on every single case, you're going to be ordering the diagnostic studies that are required by the AMA guides. So that's step number 1. Step number 2 is that when the X-ray studies are read by the medical radiologist, the medical radiologist will provide you a report basically that goes in one of 2 directions. Number 1 is the medical radiologist will use terms and descriptors within his report that you're not familiar with as a practitioner, as an evaluator. Since you're not a medical radiologist, you're not familiar with medical radiology terms. So the medical radiologist may use terms within the body of a report that you're not familiar with. If that's the case, that will require medical research on your part to investigate the significance of those findings. Number 2, if you are familiar with medical radiology and you do a lot of medical radiology yourself, the medical radiologist may miss certain things on the X-ray studies that you're familiar with. For example, I'm a chiropractor, so I'm very familiar with X-rays of the spine and all the anomalies of the spine and various conditions that can manifest in the spine. And many times the medical radiologists who have an entire scope of practice beyond just spinal X-rays, many times the medical radiologist will miss findings that I am as a chiropractor, I'm familiar with. So in that circumstance, if I identify an anomaly in a series of X-rays but the medical radiologist misses it, I will call up the medical radiologist and ask him to provide an addendum to his report that will identify the anomaly within the body of his report, wherein he initially missed the anomaly. I want that anomaly included within the body of the report if it's a significant anomaly, if it's significant to the case. So this procedure is called enlist the medical radiologist. Enlist the help of the medical radiologist in getting the proper descriptions of the X-ray studies as they actually present. Okay? So enlist the help of the medical radiologist. And I found that medical radiologists are more than willing to review the X-rays, even if they've already provided an initial report. They're more than willing to go back and take a second look. And if they are able to identify an anomaly that perhaps you identified in the X-ray studies, they're more than willing to provide an addendum to their report, which would cite the anomaly or which would document the anomaly. So number one is order all necessary diagnostic studies. Number two, enlist the help of the medical radiologist. Now, step number three is when diagnostic studies contain some abnormal findings, or if the medical report from the medical radiologist contains descriptors that you are not familiar with, this will require medical research on your part in order to understand the significance of those findings on the examinee and on the examinee's case. So as an example, I remember some years ago when I ordered some MRI studies of the lumbar spine, the report came back with some descriptors of what are known as modic changes. Modic changes. Well, I now know, I didn't know at the time, but I now know that modic changes describe pathologic changes in the vertebral end plates. And there's three basic classifications of modic changes, and each of those classifications of modic changes describes a different pathophysiology and a different history of disc degeneration. So understanding modic changes became central to understanding the condition of the examinee, understanding the timeline of the condition of the disc degeneration of the examinee. So I didn't know what modic changes at the time were. Modic changes are simply a medical radiology term that refers to findings on MRI studies. Well, as a chiropractor, I don't often order MRI studies. I don't often review MRI studies. So in that circumstance, it became necessary to do medical research on modic changes. Well, that's just one example. If you are coming up with abnormal findings on your X-ray studies, it may become necessary to do medical research on those abnormal findings in order to understand the significance of those findings on your examinee and on your examinee's case. So I'm going to share with you in this program 5 different X-ray findings that required medical research in order to provide substantial opinions and conclusions within the body of the QME report. And as we go over those examples, I'll illustrate how the medical research was pivotal in helping me arrive at the proper opinions and conclusions. Step number four, is to analyze those diagnostic studies for impairments. Now, impairments aren't the only uses for diagnostic X-rays in the qualified medical evaluation. Now, the AMA guides do require that many impairments be analyzed on diagnostic studies. Impairments such as loss of spinal motion segment integrity, impairments of the upper extremities such as carpal instability, impairments of the lower extremities such as post-traumatic arthritis. Okay, so many impairments require X-rays, but the assessment of impairments is not the only uses that we're going to have for these diagnostic studies, and I'm going to share with you some of the other uses related to causation, related to apportionment, related to the need for future medical care, etc., that we can obtain from the diagnostic X-rays. So that's step number 4. Step number 5 is to provide your opinions and conclusions, and to support your opinions and conclusions, with your findings from your medical research. And I'll show you exactly how to incorporate that within the body of your report. And then finally, step number 6 is to comply with the requirements of the complexity factors, which describe how to incorporate medical research within the body of your report. Now, this is important, and this is an area that is subject to change here in the very near future, because the Division of Workers' Compensation has proposed a new set of complexity factors, and the DWC has redefined and redescribed the complexity factors, and I'll share with you how they have redescribed medical research as one of the complexity factors. And it's my opinion, and I want to go on record as saying that the new proposed changes to the complexity factors as promulgated by the Division of Workers' Compensation are not bad changes. They're not bad changes. Sometimes we think that when the Division of Workers' Compensation comes down with a new rulemaking, that those are oppressive and suppressive and negative changes. Well, in my opinion, the changes to the complexity factors are excellent. They're perfect for us as qualified medical evaluators because they give us instruction as to how the division wants us to construct our reports, and how, if we comply with the way the division wants us to construct our reports, we can bill at the highest billing levels, the ML 104 billing level, if we simply comply with the requirements of the division. So I love the new proposed changes, especially as those changes apply to medical research. And I'll share that with you here in just a very few moments. Okay, so let's talk about the diagnostic studies, and specifically the X-ray studies that are required by the AMA guides. So before we even get into that, and we're going to talk about chapters 15, 16, and 17 and the diagnostic studies that are described within those chapters. But before we even begin and get into that, let me just say something about substantial medical evidence. Now, I know you're familiar with the term substantial medical evidence, and the term substantial medical evidence was really established within the Escobedo case. Escobedo sets the standard for what qualifies as substantial medical evidence. And one of the criteria that's described in the Escobedo case, in order for opinions and conclusions on permanent impairment and apportionment to qualify as substantial medical evidence, is that the opinions and conclusions have to be based on many, many things, including what is referred to in the Escobedo case as an adequate exam, quote unquote, adequate exam. Well, many doctors tell me that they fail to order the diagnostic studies that are required by the AMA guides. And when I review these reports, I can quickly determine that the opinions and conclusions are not substantial because they're not based on an adequate exam. An adequate exam is an exam that includes the diagnostic studies, or specifically the X-ray studies, that are required by the AMA guides. So when I point this out to doctors, I let them know that they are sitting duck and they have exposed themselves greatly for deposition, wherein one of the parties, either the applicant attorney or the defense attorney, can quickly expose their opinions and conclusions as not substantial because it's not based, because those opinions and conclusions are not based on an adequate exam. So your evaluation must include the diagnostic studies that are described in the AMA guides, and in this program we're specifically focusing on the X-ray studies. Okay? But in chapter 15 of the guides, which is the spine chapter, here are the diagnostic studies that are described. The chapter 15 describes the use of EMG. It describes the use of cystometry, which is bladder studies. It describes the use of X-ray studies. It describes CT, and it describes MRI. And you should be familiar with what the AMA guides associates with each of those diagnostic studies. Okay, so that's chapter 15. What about chapter 16? Well, in chapter 16, they describe the use of X-ray, and we'll talk about how X-ray is used in the assessment of upper extremity impairments. They talk about electrodiagnostic studies, including electromyography and nerve conduction velocity testing. They talk about the use of bone scan, laser Doppler. They talk about arthrogram, and then also MRI studies. So you need to be familiar with what the AMA guides, which impairments in each of these chapters are assessed with which diagnostic study. Then in chapter 17, the lower extremity chapter, the AMA guides again talk about electrodiagnostic studies, including electromyography and nerve conduction velocity testing. They talk about Doppler vascular studies, talk about X-ray studies, talk about advanced imaging studies such as MRI and CT, and they talk about the use of bone scan studies for the assessment of impairments related to chronic regional pain syndrome. So each of chapter 15, 16, and 17 has uses and requirements for X-ray studies. Let's now talk about X-ray studies. Okay, so considering chapters 15, 16, and 17, what are the uses of X-ray studies in the evaluation of permanent impairment? Let's take a look at each of these chapters individually. Okay, so in chapter 15, which is the spine impairment chapter of the book, X-rays are utilized for the assessment of loss of spinal motion segment integrity, and we'll go over a case that involves loss of motion segment integrity. They're also required for the assessment of acute or the late effect of fracture. And on a non-impairment basis, X-rays of the spine are always helpful for establishing the presence of pre-existing conditions, other anomalies, or other spinal conditions that may have an impact on your opinions and conclusions. For example, the presence of a pre-existing condition which shows up on X-ray studies taken immediately after the industrial injury, for example, would give you some information as to causation. Perhaps the industrial injury simply aggravated a pre-existing either asymptomatic or symptomatic condition. It may also give you great information with regards to your opinions and conclusions on apportionment. For example, you may opine that a certain percentage of the permanent impairment is due to the industrial injury, but also a certain percentage of the impairment is due to the presence of a pre-existing symptomatic spinal condition that will never go away and will never respond to medical treatment. So X-rays have many uses in the assessment of spinal impairments and spinal conditions. For the upper extremities, X-rays are required for the assessment of impairments due to carpal instability. And I have a carpal instability case to share with you, which involves some fascinating measurements on wrist X-rays. They're also required for the assessment of ankylosis and also for the assessment of trophic changes of bone as a result of chronic regional pain syndrome. With regards to the lower extremity, X-rays are required for the assessment of post-traumatic arthritis. They're required for the assessment of limb length discrepancy. They're required to confirm impairment due to gait disturbance. And if you're familiar with the table, I think it's table 17-5 or perhaps 17-7 that deals with gait disturbance in chapter 17. All of the impairments due to gait disturbance require X-ray findings of some degree of degeneration of the involved articulation, whether it be the hip articulation, knee articulation, and even the ankle and feet articulations. So X-rays are required to confirm this impairment. They're required to confirm impairment due to ankylosis. They're required for the assessment of fractures, and they're required for the confirmation of impairments due to CRPS and or causalgia. So notice here these different impairments, 1, 2, 3, 4. There's at least 5 impairments in this 6 bullet point list. And for every lower extremity case, there are 17 possible impairments described in Chapter 17 of the AMA guides. There are anatomic impairments, there are functional impairments, and there are diagnosis-based impairments. Well, we're required to assess our examinee for every single impairment. So if you have an examinee who has suffered an injury, say, to the hip, you're required to assess that examinee for post-traumatic arthritis. You're required to assess for a limb length discrepancy. All of these impairments you're required to assess the examinee for. Well, look how many of them require X-ray studies. So if you're going to do an adequate evaluation on the examinee, you must order the necessary diagnostic studies. And that is a principle. Now, in the process of ordering diagnostic studies, diagnostic X-rays, for the purposes of assessing for the presence or the absence of impairments, you may discover pre-existing conditions, anomalies, defects, deformities, or other conditions that may contribute to your opinions on causation, on permanent impairment, on apportionment, etc. And let's just say a few words about the unique nature of the permanent impairment evaluation. The permanent impairment evaluation and the physical examination and the diagnostic studies that you obtain for the permanent impairment evaluation is different than the physical examination and the diagnostic studies that you might obtain in your clinical practice. So the procedures comparing our clinical practice comparing to our permanent impairment evaluation are different. In our clinical practice, we perform a physical examination and we obtain diagnostic studies for the purpose of identifying the diagnosis. Once we establish the diagnosis can then drive the medical treatment. Well, in our QME practice, we are not rendering medical treatment. By the time the examinee gets to us, he's already received copious medical treatment, and they're with us to have a permanent impairment evaluation. So the purpose of the permanent impairment evaluation and the purpose of ordering the diagnostic studies primarily is to determine the presence or the absence of impairments. The presence or the absence of impairments. So you need to know what are the impairments. In Chapter 15, what are the impairments that are described in Chapter 15? What are the impairments that represent losses of use or loss of function of the spine in Chapter 15? In Chapter 16, what are the impairments? In Chapter 17, what are the impairments? The purpose of your physical examination and the purpose of the diagnostic studies that you order are to determine the presence or the absence of impairments. So we examine and we assess for impairments. This is different than what we do in our clinical practice. So for example, I'm a chiropractor. In my clinical practice, I do a physical examination to arrive at a diagnosis. So I do certain tests in my physical examination to assess for facet syndrome, sacroiliac syndrome, spine sprain strain injuries. And once I establish the diagnosis can then determine the treatment. Well, guess what? A spinal facet syndrome or a sacroiliac syndrome or a lumbosacral sprain strain are not described anywhere in Chapter 15 of the AMA guides. There's no impairment related to facet syndrome. So we don't need to do facet syndrome testing in the permanent impairment evaluation. The two evaluations that we do are different. So in our permanent impairment evaluation, when we obtain these diagnostic studies, our primary purpose for obtaining the X-ray studies is to assess for impairments. But along the way, we may identify other information such as defects, deformities, anomalies, pre-existing conditions that may contribute to our other opinions in other sections of our report, such as the causation section, such as the apportionment section, such as the future medical care section. Okay? And in today's, in this program, I'm going to share with you several conditions, including kidney stones. I have a case that involved kidney stones that showed up serendipitously on the X-ray studies. I have a case that involves a ponticulus posticus that I want to share with you, which is an anomaly of the C1 vertebrae of the spine. I have a case involving wrist injury, wherein the X-ray studies identified what's referred to as a negative ulnar variance, which is an anomalous condition of the relationship between the radius and the ulna at the wrist. I have a case involving patellofemoral pain, wherein diagnostic studies identified pre-existing dysplasia of the femoral trochlea, which is the groove upon which the patella glides up and down. And then I have another case that involves carpal instability, and it's going to be fascinating to go over the measurements used to identify carpal instability. Okay? So again, the principle is to order the diagnostic studies in every single case because they're required, number one, for the assessment of impairments, but also for the other valuable information that it may provide in other sections of your report. Now, here is the description of ML103, and again, the ML103 tells us that we have to follow our instructions. We must provide a list of citations to the sources reviewed and include copies of the medical evidence we relied upon. And here is complexity factor number 3, which is 2 or more hours of medical research by the physician. Now, when we use this complexity factor, the medical research as a complexity factor, we are going to follow this recipe in qualifying the medical research as a complexity factor. If we don't follow the recipe, in other words, if we don't provide a list, and if we don't excerpt or include copies of the medical evidence, then you can do all the medical research in the world that you want, but that medical research will not qualify as a complexity factor unless it follows the exact instruction that the Division of Workers' Compensation gives us. So don't refuse these instructions. On the contrary, I'm encouraging you to comply with these instructions. And this is going to be especially important in the future when there are some changes to the complexity factors if those changes get approved into law. And I'll share those changes that are proposed, that the Division of Workers' Compensation is proposing for the new language of CCR 9795 and how those changes affect how we qualify medical research as a complexity factor. For now, the current language of medical research is described in CCR 9793. And they tell us that medical research is something very specific. Okay? Tells us it is the investigation of medical issues, such as what we referred to earlier as modic changes. Modic changes is a medical issue affecting the examinee's spinal condition. Okay? It includes investigating and reading medical and scientific journals and texts. Now, here the Division of Workers' Compensation goes on to tell us what medical research is not. And I wonder, and I'm sure you can guess, how the Division of Workers' Compensation arrived at these descriptions of what medical research is not. They tell us that medical research does not include reading or reading about the AMA guides of any edition. It does not include reading about treatment guidelines, including the ACOM guidelines. It does not include reading about the labor code. It does not include reading about codes of regulations or the QME regulations or any other publications of the Division of Workers' Compensation, including the Physician's Guide. Okay, so we're expected to know the Physician's Guide, we're expected to know the AMA guides, we're expected to know the ACOM guidelines, and reviewing those reference sources does not constitute medical research. The Division of Workers' Compensation assumes that we're readily familiar with those publications and that we do not need to research them in arriving at our opinions and conclusions. It does not involve reading or studying any other legal materials, okay? So medical research is the investigation of medical issues. And we'll talk a little bit about how this definition even is going to change and become a little tighter if the new proposed changes to CCR 9795 are actually enacted into law. So let's go over some of those proposed changes. So still talking about medical research and what constitutes medical research, this could change if the proposed changes to the complexity factors is enacted into law. And the proposed changes tighten and restrict further what qualifies as medical research. So the new language of CCR 9795 with regards to medical research as a complexity factor reads as follows. It says 2 or more hours of medical research by the physician. That's the same language as we currently have under the ML 103. 2 or more hours of medical research by the physician. And here it tells us that we can use only sources that have not been cited in any prior medical report authored by the physician in the preceding 12 months in support of or relying upon this complexity factor. Now, guess why the Division of Workers' Compensation chose to include this language in its new proposed changes? It did that because we had a group of medical evaluators, qualified medical evaluators, who included the same medical research over and over in report after report and charged as if they had done the medical research newly with each evaluation. And let me ask you, how could the same medical research be appropriate to each case when the issues and disputes in each case are different? Remember, medical research is to be used in the resolution of disputed issues. Well, only if the issues are the same could the same medical research apply to each of those evaluations, in which case the evaluator should not have been citing medical research newly as a complexity factor on each evaluation, because he had already done that same medical research on the prior evaluation and had charged for it and had paid for it and was simply cutting and pasting it into the current evaluation report. So the new language by the Division of Workers' Compensation restricts evaluators from using the same research over and over again, and that makes sense. And they give us some tighter constraints as well. They tell us that an evaluator who specifies this complexity factor must also, number one, explain, here's instruction number 1, explain in the body of the report why the research was reasonably necessary to reach a conclusion about a disputed medical issue. So medical research is not necessary unless it helps resolve a disputed issue. So you don't need to do medical research on any topic unless that topic is associated with a dispute, unless that medical research assists in the resolution of a dispute. Okay? And then again, similar to our prior instruction, provide a list of citations to the sources reviewed, and 3 is excerpt or include copies of the medical evidence that you relied upon. So the philosophy of this is that when you conduct medical research and you charge for medical research and you expect to be paid for medical research, there has to be some benefit to the parties. There has to be some value to the parties for the payment that you received for the medical research. There has to be some benefit to the parties of the research. So the medical research has to contribute to the resolution of the disputed issue. Your report needs to resolve the disputed issue. If your report doesn't resolve the disputed issue, there's no need for medical research. So within the body of your report, if you conduct medical research and you charge for medical research and you expect to be paid for medical research, you need to give us some benefit for that medical research. You need to give us the benefit of your medical research. So your report should cite the medical research, and your opinions and conclusions should cite the medical research in support of your opinions and conclusions. And you must provide us with a listing of the medical research that you relied upon, and you must excerpt from the medical research that you conducted. You must excerpt or extract from the medical research the relevant quotes, the relevant phrases, the relevant findings of the medical research in support of your opinions and conclusions. In other words, give us the benefit of your medical research. Medical research that you suppress and don't elaborate on in the body of your report has no benefit to the reader of the report, and therefore, according to the Division of Workers' Compensation, will not be reimbursed because it doesn't fully qualify as a complexity factor. So these are the instructions that the Division of Workers' Compensation gives us if you want to employ medical research and if you want to submit your report at the highest billing level, which is the ML 104 billing level. Simply follow the instructions. Explain, provide, and excerpt. Cinchi. So just follow the instructions. Now, it's my opinion that the Division of Workers' Compensation favors reports that employ medical research in the resolution of disputed issues and in supporting your opinions and conclusions. And that makes sense. And support for this opinion that I'm forwarding here to you, that the Division of Workers' Compensation favors medical research, comes from, again, new proposed changes in the language of medical research as a complexity factor. So they tell us that under the ML 104, which is the highest billing level, that we're required to spend 6 or more hours on any combination of the 3 complexity factors which are described in ML 103. So to review, the 3 complexity factors described in ML 103 are face-to-face time, review of records time, and medical research. So if we accumulate 6 or more hours on any combination of those 3, then our report, well, those qualify as 3 complexity factors. And then simply we need a 4th complexity factor to qualify for the ML 104. Well, the new proposed language includes the following. It says that 6 or more hours on any combination of the 3 complexity factors, provided that some portion of time has been devoted to each of the 3 complexity factors. Any complexity factor used as a standalone may not be used in combination under this subdivision. Now, this is new proposed language. And up till now, there have even been cases where doctors have been disciplined for using this description, 6 or more hours, even in reports that did not include medical research. And the argument was that the description of this language says on any combination, So doctors argued that they could have 3 hours face-to-face, 3 hours review of records, and 0 hours of medical research, and their total is 6 hours, and under that condition or that circumstance, they would qualify for the 6 or more hours. Or another doctor would argue that he had 2 hours face-to-face and 4 hours of review of records and 0 hours of medical research, and because the total was 6 hours, and because the combination, it says any combination, and 4 and 2 and 0 is a combination, and 2 and 4 and 0 is a combination, and 3 and 3 and 0 is a combination, the DWC has changed that to require that some portion of time has been devoted to each of the complexity factors. So under this new language, we cannot have 0 time as a combination. 0 time does not qualify as a combination. We must have some time devoted to each complexity factor. So when I first heard about these new proposed changes, I thought to myself that the Division of Workers' Compensation is trying to twist my elbow and trying to force us into doing medical research that may or not even be necessary. But in order to qualify for the 6 or more hours, we had to have some time in medical research. And I thought, this is going to force me to do unnecessary medical research. But I've reinterpreted and realized that this descriptor of requiring some time of medical research is the Division of Workers' Compensation's way of encouraging us to include medical research in support of our opinions and conclusions in these cases that are the more complex ML104 cases. And doesn't that make perfect sense? Is there any problem with that? What's wrong with requiring us as physicians to conduct medical research that supports our opinions and conclusions and assists in the resolution of disputed medical issues? What's wrong with that? There's nothing wrong with that. In fact, that is what's going to contribute to a vast improvement across the board in the content and quality of QME reports. If every QME begins to incorporate medical research in support of their opinions and conclusions, we'll actually have reports that resolve disputed issues. What a concept. What a concept. So many reports that are authored by QMEs nowadays, they don't resolve the disputed issues. And here with this change in the proposed language, the Division of Workers' Compensation is encouraging us to use medical research to support our opinions and conclusions so that we can actually provide opinions and conclusions that are substantial medical evidence so that our reports can actually assist in the resolution of disputed issues. So this is a lot. The Division of Workers' Compensation is requiring a lot, but it's not difficult. And let me show you how this will look within the body of your report. Okay, so this is how this is going to look in the body of your report. Remember, the complexity factors under CCR 9795 tell us that we are to include a separate section in the beginning of our report wherein we elaborate on our use of the complexity factors. So when we're qualifying our report as an ML104, and we're claiming that we spent 6 or more hours on any combination of the 3 complexity factors, including medical research, remember that we're required to do at least 3 things. We're required to list, we're required to explain, and we're required to include citations. So this is how this would look in the section, at the separate section at the beginning of your report. You would tell the reader of the report that you spent 6 or more hours on any combination of 3 complexity factors, which is review of records, face-to-face, and medical research. Total time involved with face-to-face, and give the reader the total time. With review of records, and give the reader total time. And medical research, give the reader total time, was X number of minutes, and provide that in terms of number of hours total, and make sure that the hours total exceeds 6 hours. Then comply with instructions and give the reader of the report a listing of your citations. So you would tell the reader that the medical research consisted of citation number 1, and list your reference here, whether it be a textbook, whether it be a journal, whether it be an online search that you did. Give the reader the citation that you researched. Give the reader your second citation, and I suggest no fewer than 2 citations, and possibly as many as 3 citations, all focused on the same disputed issue. 2 is adequate. 3 is perfect. 4 would be excessive and unnecessary. So probably, and there's nothing described in any rule or law on this, but probably 2 citations is adequate. 3 would be certainly more than adequate. 4, in my opinion, would be excessive and unnecessary. After you list the citations, then refer the reader of the report to the section in your report wherein you discuss your medical research, and send them directly to the page number so that they can easily see and easily benefit from the medical research that you conducted. And in this section, this medical research section, you're going to explain to the reader why the medical research was necessary. You're going to provide the reader of the report with your findings from the medical research. You're going to associate those findings with your opinions and conclusions. And then along with your report, you're going to include copies of these citations along with the copy of your report, so that the readers of your report will have instant access to this medical research that you conducted. And we'll get into this medical research section later on in this program as we go over our 5 case examples. Okay, doctors, so I hope this helps you, and I hope that this excites you for the future of your QME practice. You know, the rules, regulations, and laws that are promulgated by the Division of Workers' Compensation are not intended to hassle us or harm us in any way. And if you review the QME regulations and you review the complexity factors, they're really nothing more than a set of instructions to an end product. The end product being an awesome QME report, a report that hits all the bases, hits all the high notes, and actually resolves the disputed issues. And it provides the instructions for providing a report that's commensurate and equal to the amount of dollars that qualified medical evaluators want to get for their QME reports. It's ubiquitous that qualified medical evaluators want to be highly paid for their QME reports, but it's not ubiquitous that qualified medical evaluators provide quality, substantial reports that actually resolve the disputed issues. So the QME regulations and the complexity factor descriptions are simply intended to help us provide better and better quality reports that match the billing levels that we hope to be paid for those reports. And in this program, we're focusing on 2 aspects that will dramatically and instantaneously improve the content and quality of your QME reports. And that has to do with procedures that are required. It's required that we order diagnostic studies in almost every single case. So begin now to adopt this with your very next evaluation. And then one aspect wherein we can incorporate medical research has to do and piggybacks on the diagnostic X-rays. So when you have abnormal findings on the diagnostic X-rays, this is one opportunity, this is one excellent opportunity to include some medical research in your report and really provide the reader of your report with some value, with some strong opinions and conclusions that are supportable by medical research. Opinions and conclusions that are supported by medical research are correct opinions. They're substantial opinions, and they are irrefutable, indisputable opinions and conclusions because you provide the reader of the report with references that support those opinions and conclusions. Now in our next session, we're going to begin our breakouts, and we're going to talk about specific medical research associated with specific findings on X-ray studies. And you're going to find this to be a fascinating program, and I'm sure you'll get many, many ideas that you can incorporate into your very next evaluation. So for now, this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on today's video. Look forward to being with you over our next 5 sessions as we explore our new series entitled X-rays and Medical Research in the QME Evaluation. For now, I'm wishing you best of success in your career as a qualified medical evaluator.